We're good to go. Did you go to the next slide?
Start it.
Yeah, let's go ahead and start. Don't worry, there's not a question that pops up right in the beginning, so you got a second here. I did that. You didn't do that, right? Okay, I think I did that. All right. So here's the first case we're going to talk about. All right. So 20-year-old female stung by a bee in a cemetery, no less. All right. Mom states when she calls 911 that the patient was in and out of consciousness. Mom did give her some Benadryl, 50 milligrams before EMS gets there. Her ankle's red and swollen. She's got no hives, no oral facial edema. She was complaining of shortness of breath before you get there. She is awake when you arrive, no respiratory distress, but mom said that she seemed like she was like near syncopal at the time. Her blood pressure is 105/78. All right. So here's our first question. Your ALS ambulance arrives, you and your partner. How would you treat this patient? There's your choices up there. I'll read them. EpiPen immediately, transport BLS for observation, let them sign AMA as the patient's improved, right? Or transport ALS and give steroids. All right, so we got a little mix of responses there. So the answer is transport ALS and give steroids, which I think is what most people were thinking. Now, there's a couple of other ones that came up there, right? EpiPen immediately. This person has no respiratory distress, probably not any reason to give epi right now. Blood pressure is good. But the reason that we would transport ALS over BLS is that if you have ALS available, and this is somebody who's been near syncopal, maybe had some borderline hypotension before you got there, or had that severe symptoms that you're at least concerned, there's a high potential you may need to give epi or they may deteriorate on the way. You should go ALS if available. This is something we see pretty frequently, is that people are getting some, more higher risk medications or more ALS type medications, even though EpiPen is in the BLS scope of practice. And if you have ALS available, these should still warrant a paramedic monitoring just in case things go south on the way. All right. So I'm going to skip through our scoreboards and stuff, and we can look at these at the end. So here's your next question. Now, suppose you were just a BLS ambulance, no paramedic. Now, how would you treat this patient? Do you transport BLS, give that be an albuterol if needed, call for ALS and intercept en route, call for ALS and wait for them to get on scene, or call med control for guidance? All right. And the majority of people say transport BLS, monitor for worsening, give epi and albuterol if needed. That is the correct answer. So here, this is what we're going to talk about a bunch of times tonight. Is it's going to sound like I'm saying one thing, and then I'm saying the exact opposite thing. And what I want to distinguish is the kind of that dichotomy, right? That's what differentiates the good providers from the not as good providers, right? It's that higher level thinking to say, what is my scene? What are the logistics? What's the best thing for the patient? And so if I have a paramedic available, we should transport this patient ALS. But if waiting on scene, if I'm 10 minutes from the hospital, waiting on scene is going to delay getting ALS, or if they're doing okay right now and I have the tools that I need, such as epi and albuterol or CPAP if I need it, then our BLS providers should certainly function at the highest level of their scope. And so we would encourage them to transport that patient, not delay on scene and not wait for ALS. Does that make sense to everybody? All right, I think it's pretty straightforward, right? But I don't want anybody to get confused on why I said ALS and then said BLS. So good. Let's move on here. It sounds like everybody's keeping up with the questions and that and getting the answers in on time. So this one is, when should epinephrine be given? Select all that apply. All right, you can read them there. Trouble swallowing after eating nuts, worsening hives after Benadryl, mild rash, no edema, mild wheezing. Somebody stung by a bee, history to allergies, but no symptoms yet. Somebody stung by a bee, no hives, but the blood pressure is 80. And then a peanut allergy with nausea, abdominal cramps, and low blood pressure. All right. So obviously there's multiple correct answers here. So this is another big thing that we see when we look at some of these cases, right? Especially this time of year, lots of bee stings, lots of allergy versus anaphylaxis, right? The question is, when do we give epi? When we give epi, we want to give it because there's some true life-threatening concern or reason that we need the epinephrine as opposed to just Benadryl or steroids. But we don't want to overgive it if not needed, right? Because epi is not a benign medication. But when we need to give it, we don't want to hesitate to give it. So if somebody's having trouble swallowing after nuts, right? If somebody has trouble swallowing or breathing, obviously that's a reason to give epinephrine. Same with the one in the bottom left there, right? If they've got mild wheezing, they have some airway compromise or airway issues already, that's an indication for the epinephrine. And then the other thing is, even if they don't have hives, but they have hypotension, or especially if they have abdominal symptoms, you can have anaphylaxis with abdominal symptoms, cramps, nausea, vomiting, and hypotension without any outward hives. It's more rare, but it does happen, and it is referenced in the state protocol. So those are all things to think about. One of the things that we often see epinephrine given for when it should not be is that if you have hives, but you have no hypotension, no trouble breathing or swallowing, and the hives are getting worse, that's just the normal, allergic reaction or the inflammatory reaction to the venom. So if the hives are getting worse, but they're just itchy and there's no swelling of the lips or the tongue or trouble breathing or low blood pressure, then that would not be an indication to give epinephrine. And that's another thing that we see, when it's commonly misgiven. So let's see here. Can you advance that? Because I'm not clicking. There we go. All right. So we're going to stick one more case on this anaphylaxis kick, and then we'll move on.
They talking about anaphylaxis. I guess some people be like doing the whole protocol for like if someone's, how like anaphylaxis is like 2 or more body systems. Like I feel like people just be giving it whenever like like it'll just be an allergic reaction or something. They just give the whole protocol.
So I'm not sure what the question was there.
I mean, most anaphylaxis suspected in the
Actually, yeah. So
ask Jaisha if she's talking.
What's that?
Ask if Jaisha is talking.
Jaisha, did you mean to ask a question?
oh,
or are you
I'm
just
so
talking?
sorry. I didn't know you guys could hear me. Let me mute me.
All right. I guess there wasn't a question there, but obviously some good commentary. So now some things to think about. Somebody's going to go back and reread that protocol. So that's good. I guess we're getting somewhere already. All right, here's the last question. All right. So now you're called to an urgent care. All right. Male stung by a bee an hour ago. So this is over an hour ago. He had lip swelling, hives, and wheezing. He's given epi in the urgent care, also Benadryl and dexamethasone already. Improves before you get there. No respiratory distress. Hives are improved. No trouble speaking, breathing, or swallowing. Vital signs are all stable at this point. All right, so really no distress here. So now, how do you manage this patient? What should you do? Let them sign off because they feel better and there's nothing else the ER will do. Transport them ALS because symptoms can return. Transport BLS because they have no current symptoms. Or tell urgent care to discharge the patient. There's nothing else you're going to do for them. All right, and most people got it correct, right? It's transport ALS like we talked about before. One of the things that comes up frequently is this question of, well, they're better and they're improved. Why do they need to go to the hospital? And what do we do for them? And a lot of times when we look at these cases, right, and we've actually had providers who've said to the urgent care staff, well, we're not going to do anything. They don't need to go to the hospital. And I think we all realize that that's not the right answer for a couple reasons. And one of the things is that I want everybody to remember is, just because we see one subset or we focus on treatment in one subset of the continuum of medical care doesn't mean that we always know or understand how things are going to play out or what the disposition would be for those other parts of the healthcare system, like in the ER or someone admitted to the floor as an inpatient. So just so everybody knows, if someone has, a simple allergic reaction and they just get some Benadryl, right, or some steroids, that's not as big a deal. But anybody who gets epinephrine, right, even just one dose of an EpiPen, automatically gets monitored in the ER for a minimum of 2 to 4 hours, right? If you rise to the level of anaphylaxis and get epinephrine, there's a high rate of relapse, up to 23%, where 23% of the people will need a second dose of epinephrine. So they automatically get observed for that period of time. And then if they require a second dose of epinephrine, or if they have a slow response to the epi, not back to their baseline, still hypotensive, or if they had a delayed onset where they got stung, let's say, or they ate something and then it was over an hour before they had symptoms, those are criteria where sometimes we even observe them and watch them for 24 hours in the hospital. So just because they're improved doesn't mean they don't need to go to the hospital. I think a lot of people know that, but we've seen some questions of that come up in our reviews. Yes, question.
Not really anaphylaxis related, but it is on the side of like Dex and Benadryl.
Mm-hmm.
But Dex, not Benadryl. So Dex, albuterol, ipratropium, you're giving those for the wheezing. I had a patient the other day she was an asthmatic, but she was also 37 weeks pregnant. The saturation was good with the treatment with the albuterol, but I wasn't sure about the Dex. Like, Dr. Catillo said it was fine to err on the side of caution with that, but would you, if it was like worsening saturation, would you then give them Dex?
So was this, so I'll repeat it for everybody online in a second, but is this, are we talking about just an asthmatic patient? Or are we talking, or was it a possible allergic reaction as well?
She has an exposure to, I think it was like tree nuts.
Okay.
She wasn't sure.
All right. So the question was, in a pregnant patient who has a history of asthma, but had a potential exposure to tree nuts and allergic reaction, this person required Benadryl, correct?
Yeah.
Also with albuterol and ipratropium, the question is, should you or should you not give steroids, dexamethasone, if they're pregnant? Is that the question, right? So if it's a pregnant patient, we don't treat them any differently when it comes to asthma, COPD, or anaphylaxis with regards to steroids, right? The risk-benefit ratio, the benefit to the patient and to the baby still outweighs any potential risk of giving the steroids. So if you would give them to someone who wasn't pregnant, you would give them just like you would in that patient to someone who was pregnant for the same indications.
Even, would you say even like, because he's improving with?
So if it was just asthma and they got one neb and they improved, you could say maybe they don't need steroids. In this case, if there was any question about it, whether it was from an allergy exposure to something, then I think there's even more reason to give the steroids. So I think in that instance, I would give the steroids. If it had been someone who just got one albuterol and their asthma got better, then maybe I wouldn't. The allergy thing changes it. Or if it was someone who got multiple nebs before they cleared, then they certainly would get steroids. Does that help? All right. Perfect. Also, I forgot to mention for the people watching at home, I think you all figured out Brian's running the chat function there. So if you have questions, you can put them in there and he'll be happy to convey them as we're going through. So, all right, we're going to switch directions a little bit. We're off the anaphylaxis topic here. And we're going to move on to some trauma cases. So we have a 20-year-old male. He's a restrained driver in an MVA. He's unresponsive. He's extricated, or they're just getting him extricated on your arrival. GCS is 6. He moans and he flexes to pain. He's got some decorticate posturing. His right pupil is blown, right? So he's got unequal pupils. Abdomen's distended, open tib fib fracture. His blood pressure, he is hypertensive. His heart rate is 64. Pulse ox is 93. And he's got some irregular, shallow respirations and periods of apnea. So here's your quiz. These vital signs are called what? Hypertensive, low blood pressure, and irregular, shallow respirations. All right, and the answer is Cushing's triad, right? So that's hypertension, bradycardia, and then irregular, abnormal, or Cheyne-Stokes respirations. So that's an indication of what? Increased intracranial pressure that we see in head trauma, right? Can you hit the next button for me? Hit the next again. All right, so here's your quiz. You feel that this patient needs some ventilatory support. What is your best option for this patient? Intubate because their GCS is less than 8, intubate then hyperventilate, BVM and immediately hyperventilate because you're worried about herniation, or start oxygen and BVM at a rate of 10. A lot of options there. All right, so most people said BVM and immediately hyperventilate because the patient's about to herniate. We're gonna talk about this. So the right answer is actually to start supplemental oxygen and to bag at a rate of 10 breaths per minute. All right. In head injuries, our standard start for what rate we ventilate at should be very similar to now your CPR or your ACLS and PALS guidelines, depending on their age. All right. In the old days, we used to talk about hyperventilating, and I'm going to come back to that in a second, but hyperventilation for head injuries is not recommended any longer. And we'll talk about that a little bit more as we go on. All right, so here's a question. In your EMT or paramedic class, you were taught to hyperventilate head trauma patients to prevent herniation. Yes or no? Everybody answered quick. So everybody, the majority of people are saying yes. So we have found in some of these reviews of looking at this that even though it's no longer recommended to hyperventilate patients that you think may be herniating and that there is no proven benefit to it and they actually will do worse, that it's still being taught in EMT and paramedic classes, even for people just coming out. All right. So this is going to be small and probably you won't be able to read it whether you're here or you're at home, but I'm just going to show you. This is a state CMAC advisory that came out, and it basically talks about this specifically and says aggressive hyperventilation should be avoided in the pre-hospital setting. It goes to talk about studies not showing any benefit and showing some harm. So here's the question, right? We're still being taught this in class. This CMAC advisory is out there. What year do you think this CMAC advisory came out? Multiple choice here. 97, 2004, 2010, or 2016? So most people thought it was more recent, but the correct answer is this came out in 1997. All right, a long time ago. So my point of this is that this is not necessarily new science, but yet it has been slow to trickle into our EMS and paramedic education. Not a fault of our providers, but it is something we need to work on in our educational system, and why I want to spend a little time talking about it today, because we are still seeing new paramedics coming out who were taught to hyperventilate these patients. Yes, Frank.
So the hyperventilating, I was taught not just in my actual paramedic class, but ITLS and PLS. They both have that ultimate curriculum and even the slides that they provide. So,
Well, I will defer to someone such as Jeff or Sean on whether that is still in the ITLS curriculum, but I will tell you, do not do that.
look at the temperature of PHCLS.
All right.
I can tell you absolutely, PHCLS gives exactly those target numbers: 20 for an adult, 25 for a child, 30 for a ped, and they give you a target and double CO2 of 35. That is 9th and 10th edition PHCLS. I can't speak to ITLS. Well, I should be able to, but
Yeah, ITLS gives you a target.
End title? End title. All right.
Is that
So-
one?
What?
no. So that's
So-
the mistake. I think we're talking about hyperventilation versus a targeted ventilation that's faster.
Correct.
I hear hyperventilation, that's what I think is target CO.
So hyperventilation is bagging more than normal, right? Your normal end tidal CO2 is roughly 40 or between 35 and 45, correct? If you are bagging to maintain an end tidal CO2 between 35 and 45, that's not hyperventilation, right? That's our goal of where our normal ventilation should be, correct? Okay. So when we talk about hyperventilation, it's people being taught to bag down with an end tidal below 35 or down even to 25 in the old days. All right. So I'm going to come back and talk about some hyperventilation in a second. Go ahead, Brian.
Just for BLS providers who don't have benefit of ventilators.
Yes.
It's a rate of 20 is faster than the 10 to 12 that would normal ventilation. Almost 2 to 1, just addressing.
Yeah. So that's a good point. So when we're talking about, and I'm going to talk about this a little bit later, but we'll address it now since it's coming up. when we're talking about ventilatory rates for head trauma patients, right, we should start at a rate just like you would for CPR of 10 breaths per minute. All right. For an adult, we're talking about. All right. When you have the ability to monitor end tidal CO2, then you can adjust your rate to make sure you're in that range of 35 to 45, right? Or hovering right around 40 is our goal. All right. But until you get to that point where you have end tidal available, or if you're just a BLS provider, then we're going to start bagging at 10. What we see is that most people tend to overventilate or hyperventilate in a whole variety of situations. And why do you think that that is? Why do we tend to bag too fast? Yeah, adrenaline's one, right? Sometimes they're hypoxic. Sometimes, maybe we didn't put a PEEP valve on, and so we're hyperventilating because it's helping to keep some pressure in the lungs, right? All those things, or it's just a chaotic scene that's releasing adrenaline, or we're not paying attention. All those things lead to overventilating the patient, to hyperventilating, which actually can be worse for them. So we want to maintain a normal ventilatory rate and end tidal CO2 for these patients. And I'll come back to that in a second. So we'll talk more about it. So there are a ton of different guidelines on trauma, right? And we already mentioned PHTLS and ITLS. One of the big drivers of head injury trauma guidelines is a group out of Arizona, at the University of Arizona, and it's the EPIC TBI guidelines. These are now incorporated into a lot of state EMS protocols, not yet in New York, but Pennsylvania, if you go over the border, already includes these. And their big focus is our goal in head trauma patients or potential head trauma patients, right? Because sometimes they could be unconscious from, torso trauma, chest, abdominal trauma. We don't know, but there's a potential for head injury. Our goal in those patients is to prevent secondary injury. So what's a secondary injury versus the primary injury when we're talking about head trauma? What's that? No.
Say it.
Yeah, so the primary injury is from the trauma, right? It's the actual traumatic injury, whereas the secondary injury is things that we can prevent, right? So how we protect the brain from those secondary insults. Those are things directly within our control as EMS providers, right? But they talk and they term them the H bombs, and they say to avoid the H bombs. And those are three things: hypoxia, hypotension, and hyperventilation. We're going to talk a little bit about each one of those. So what is the effect of a single episode of hypoxia in a TBI patient, right? Is it a minimal decrease in morbidity and mortality? Does hypoxia cause bradycardia, hypotension, or does a single episode of hypoxia double the mortality rate? All right, good. And most people got it right. So the effect of a single episode, just one episode of hypoxia in a trauma patient, in a head trauma patient, literally doubles the mortality. And that's why I think it's important to talk about ventilation, to talk about the H bombs, and why I think we need to bring it up. For those of you who just are kind of jumping in late, either here in the room or online, if you go to on the bottom of the screen there, you can see it says kahoot.it. And it's got the game pin. You can go to that website, type in the game pin, and you can participate as well. All right. So one episode. So they could be hypoxic in the field. You get there, you put high flow oxygen on them. They get to the ER, their oxygen is normal. They still have twice the mortality rate of somebody who wasn't already hypoxic, which is a huge, huge difference. Okay. All these things we're going to talk about have significant impacts, and why I want to drive these points home for you. So when we talk about preventing hypoxia, all right, the goal is for a minimum pulse ox of 90%, right? If you actually read the state protocol, our general goal for oxygen is what in New York State? What does it say in your protocol? Right, so we want it to be above 90, right, titrate to over 94. There is now mounting evidence in things like strokes and heart attacks that giving too much oxygen can be detrimental. And I think people know that, right? If the SAT's over 94, we don't have to give any extra oxygen. And you'll see some guidelines between that 92 to 94 range, because some studies are a little bit different, but anywhere in there, is where we want to be. In trauma patients, right, it's a different physiology. And so most of the trauma guidelines still recommend giving high flow oxygen or not withholding oxygen in trauma patients, all right? Trying to increase the oxygen saturation of hemoglobin or dissolved oxygen in the blood, because it is a different pathology, and usually it's due to hypovolemia and bleeding out, All right. So it's a little bit different. If you go to any of the case reviews, like when ECMC holds them, they often are pushing, make sure you put your trauma patients on high flow oxygen. I don't think you need to put everybody on a non-rebreather, but we should have a low threshold in trauma patients and head injury patients to make sure that we prevent and don't allow them to become hypoxic. All right. We should, if they need it, make sure we put oxygen on during extrication if possible. Use your nasal pharyngeals, your OPAs when needed. And the guidelines also say, and this is now, even if you were to look at PHTLS, I'm sure ITLS is the same, and some of the other guidelines out there say, in trauma patients, we don't need to rush to advanced airways if we can adequately oxygenate and ventilate. We should use BVMs with OPAs or NPAs if we can adequately oxygenate and ventilate. And what's the reason for that? What happens when we try to intubate these trauma patients? What do we see happening? We see a couple of things. One, the intubation procedure leads to them becoming hypoxic and or hypotensive during the intubation, right? And it also delays us on scene. And we know for these major traumas, our on scene time, target goal should be less than 10 minutes to get on scene so we can get them to a trauma center, right? As opposed to some of these medical cases where we may actually be doing interventions before we start extricating or moving them out of the house, right? Trauma is a little bit different. And so that's why those things are there. So only go to advanced airways if we can't adequately oxygenate and ventilate. Again, this all comes back to good BLS management, but yet we see a lot of times we don't get a good two-person, seal with a mask, one person bagging, and then we're not adequately ventilating or managing the oxygenation in this patient. So moving right along, still on the head trauma patients, the target blood pressure for a head injury trauma patient is what? 90, 100, 110, or I don't know, no one really knows. All right, so we're kind of all over the board, and you'll see that every single answer here is correct because I don't know, no one really knows. Now, somebody here in the back of the room is going to try to pull up the ITLS, whatever current edition guideline there, Jeff, and tell me what it should be. But I'm going to tell you that everybody seems to have a different answer of what that target should be. All right. EPIC, right? The EPIC TBI guidelines we're talking about, and PHTLS say greater than 90, like, permissive hypotension. The Brain Trauma Foundation says 100 to 110, but it depends on the age. TCCC, TECC all say something a little different, but everything's kind of in that 90 to 110 range there. So then we come up to the question, what should we do? What's the answer, and what blood pressure should we be looking at, right? We don't need to keep a blood pressure super high in trauma. In fact, we don't want it high for internal injuries, right? Because we don't give them 2 liters of fluid anymore, right? We want to just give them enough to keep the blood pressure around 90. That prevents them from diluting down their hemoglobin, their clotting factors. If you increase the pressure, sometimes it can rupture a clot that started to form. We don't want that. So we take a more permissive hypotension strategy, right? Small boluses of fluid, keep the blood pressure right where we want it, right around a target of 90. That's without a head injury. Now, with a head injury, the concern is we might need a little bit of a higher pressure for what? We want to have a higher systolic pressure because that gives us a higher cerebral perfusion pressure or higher pressure pushing blood to the brain. And we want to have that blood pressure to prevent that secondary injury. But where that goal is a little bit of an area of debate. And so I'm going to tell you that you have to balance not giving too much fluid or giving too high a blood pressure for your internal injuries while trying to make sure you have enough pressure to go to the brain. So I think somewhere in that 100 to 110 range is probably where most people will fall or will recommend. But really, you're going to be okay anywhere that you are. If you have a trauma patient that you think is still bleeding out internally and with a non-compressible hemorrhage and you can't stop the bleeding, you may aim for a little bit lower, like in that 90 to 100 range. If it's something where it's an extremity trauma, you've been able to compress it, tourniquet it, pack the wound, stop the bleeding, then maybe you can go a little bit higher and you're more in that 100, 110 range, but anywhere there is going to be okay. I don't care exactly what number you're aiming for, right? I mean, I think anywhere in there you can make a justification for because the guidelines are all over the place, but I want you to understand the why behind it and why we're giving just a little bit of fluid and aiming for that target range. All right. Any questions on that? Because I know it's a little bit confusing. No? Any questions in the chat there? Good. All right. Then I'll just keep asking questions here. So we talked about hypoxia. Now, one episode of pre-hospital hypotension in a trauma patient results in, and select all that applies. Double the mortality rate, no change in mortality if the blood pressure is normal on ED arrival, 3 times increase in emergent surgical interventions, or increased likelihood of a head injury. All right, so the 2 correct answers are it doubles the mortality rate and there's a 3-fold increase in emergent surgical interventions. All right. So just like we said, one episode of pre-hospital hypoxia has a huge prognostic, impact on the patient about what their mortality will be. So does one episode of hypotension. And that holds true even if their blood pressure is normal when they get to the ER, that effect still happens. One of the big things the trauma services want to see is that if you have a patient who is hypotensive in the field at any time, they want to make sure that you communicate that in your pre-notification because that changes sometimes their level of activation or how they're going to approach that because it does affect both mortality and the need for surgical intervention so much. All right. So sometimes we look at these patients, right? And I know this seems like I'm hammering some of the these basic things, but I think very often we have a trauma patient, we get there, they're hypoxic, we put them on oxygen, they're better, and we think, okay, great, we move on. Or their blood pressure is a little low, but I didn't even give them fluid and now their blood pressure is better, no big deal, and it gives us a false sense of security. The reality is that just that one episode has a huge effect on their outcome, and then we have to be very careful to, maybe start to put oxygen on, have fluids ready to go, or intervene if they start to become hypoxic or hypotensive in the future. All right. Moving through. Next question. Hyperventilation, decreasing the end tidal CO2, results in which of the following, and this is a select all that apply. Cerebral artery vasoconstriction, increased secondary injury, decreased cerebral perfusion, or all of the above. And the answer is all of the above, right? And this is why we want to avoid that hyperventilation we talked about before, or your end tidal dropping too low. All right. When you do that, your arteries in your brain constrict, you decrease oxygen supply, both blood flow and oxygen supply to that brain tissue, and it increases the rate of secondary injury. All right. So we talked about this before a little bit, right? But it really has a very profound impact. And we used to think that if someone started to herniate, they had that blown pupil, we would hyperventilate. It would be a temporizing measure. It would decrease some of the swelling temporarily, and it would buy us some time to get to the hospital. And now we find out that if we do that, it actually doesn't have any benefit, and it actually makes those patients worse. All right. If you're properly ventilating these trauma patients, like we said before, the tendency is to overbag. If you're properly ventilating, it will feel like you're almost going too slow because it's one squeeze and then you're literally waiting 5 or 6 seconds. I was at a conference one time when the people from Arizona presented their latest research, and they actually said, if you squeeze the bag, you let the paramedic get out the side door of the ambulance, run around the ambulance, come back in, it's almost time to squeeze again. All right. Some people are faster than others. Yeah, I see the look.
Diagnostic PHCLS studies recommend hyperventilation. 20 for adults, 25 for a child, or 30 for.
Well, I'm going to tell you why that's wrong at the end.
That's wrong. So you know that.
Right.
Those are exact membership meeting. They're just using the term hyperventilation for that.
Yeah.
So they're saying 20 breaths per minute is hyperventilation.
Okay. All right. So, so we talked about most of this stuff already, right? Is that start at your same kind of goals of your CPR and your PALS, and then adjust based on your end title there. So, and I just want to say, but just to go back, Brian, so ITLS is saying start at a ventilatory rate of 20,
HTLS
is saying 20. PHTLS. Okay. Okay,
They
okay,
They offer both, because if you don't have that title, it's for isolated head trauma, it's for TBI.
Okay.
Ipsilateral or contralateral dilation.
all right.
Good
So-
try. It's specific.
So I think some of those things are starting to catch up with the data, and I'll talk about the actual results of the EPIC trial and what they did in a second, and why I'm spending the time talking about it, right? So the question always comes up again, what about that herniation? What about temporizing it? And when they looked at the evidence, right, they found that true herniation in the pre-hospital setting is actually very rare, and it's also hard to identify. And the reason is that most of the time you can have non-herniating patients that have the same symptoms or same signs, right? With coma, posturing, unequal pupils, a dilated blown pupil, focal weakness, kind of Shane Stokes respirations. They could have all those things or any few of those and not actually be herniating. And so when we thought we were hyperventilating for a potential herniation, we're actually hyperventilating someone who didn't have a herniation. And their conclusion was, and the pre-hospital therapeutic hyperventilation has essentially no chance of improving the outcome in true herniation, but harms people, survivable patients who present with herniation-like symptoms, and why we should not do that in the field at all at this time. All right, so start with your regular ventilatory rates and then adjust based on your end tidal CO2. All right, and so this is a little busy slide. This is actually their slide in the latest study that came out recently of this, and this was like somewhere between, I think it was 12,000 or 28,000, like a whole number of patients in the pre-hospital setting. And they showed that if you had a severe TBI, just following those guidelines of preventing the 3 H bombs, right? Preventing hypotension, hypoxia, and hyperventilation, and severe TBI doubled the odds of survival. And for those that had severe TBI that were intubated, it tripled their odds of survival, right? Very simple, basic things that I think we overlook a lot because they are literally BLS skills, and because we tend to focus on all these advanced trauma managements and fluids and IVs and all these things. And just those simple basic things can make a huge impact. The other thing that they found on the bottom there that's really important is that the average time with EMS, average field time, in transport from arrival at the patient to arrival at the hospital was 29 minutes in their study. And they showed that 29 minutes of EMS care actually affected, if they followed those 3 things in preventing the 3 H bombs, actually affected survival to hospital discharge down the road, right? And that's another thing I don't think that we focus on enough, is how those little things that we do or don't do make a huge impact. And in this case, it's literally basic skills that we have to know and own inside and out that have a huge impact. It's not crazy, a lot of times crazy ALS interventions. It's just doing the basic stuff very well. All right, so that's one of my take-home points for today. All right, how are we doing on time here? We're good. So
Nick Smith asked how
Yeah.
EMS time affect outcome.
So that's a good question. So you're asking, was there a correlation between time, total time with EMS and the outcomes? And I don't believe that they found, or at least didn't comment on any difference in timeframes, like if the EMS time was 10 minutes versus it was 40 minutes. Their conclusion was that the average time was across all things was 29 minutes, and that time with EMS, regardless of where it felt, but with a mean of 29 minutes, had a significant impact down the road. So any other questions there before I go on? All right. So I've got a few cases here. All right. And this is going to be seeing the forest through the trees. What we're going to focus on here is where we fall in relation to the whole continuum of healthcare. Again, I think it's easy to get focused on the stuff that we do very well day in and day out, that we know and we own because it is emergency medicine, right? And not everybody in the healthcare system knows emergency medicine as well as we do. Sometimes we go to places, offices, facilities where maybe they aren't as familiar with the treatments and things that we are, but yet they also know things that we don't and play an important role in that continuum. And so we're going to talk a little bit about that as we go through. So the first case is a 90-year-old male. And if you haven't figured out, these are all based on real cases. Some of the details I have changed slightly, but just for either teaching purposes or to protect the not so innocent. but these are all cases that we have had and seen here at Twin Cities. So you have a 90-year-old male. He's in a nursing home, new onset stroke symptoms just started. He's got chronic dementia, so he can't give any history. Vital signs are stable. He's got an apparent new facial and arm weakness. He has a difficult assessment, like just because of his chronic dementia, you can't get a good neuro exam completely on him. The nursing home staff states that their doctor says he needs to go to the ER, and you pull out the MOLST that they hand you, and it says, do not send to the hospital. Now, what do you do? Right, we've all been in this situation. So you ask to speak to the nurse or the supervisor to discuss the care, ask the demented patient what they want to do, discuss with the power of attorney or next of kin, tell the staff that you refuse to take them to the hospital because of the MOLST, or call medical control for guidance and select all that you think are correct. All right, so I'm just trying to look here. So good, I think that we selected all the correct ones, right? This is something we see pretty frequently. And I think all of you have been in some type of situation like this from a nursing home or assisted living in one way or another, right? The best things to do, right, are asked to speak to the supervisor or the RN, or to discuss the case with the power of attorney or the next of kin. And then if there's any issues or discrepancies, right, we've talked about this before, is involved medical control. The thing, go ahead, Brian.
Just want to say we have a comment.
Yeah.
Most questions are upset.
Most questions are upsetting.
I'm asking for elaboration, but I'm assuming.
Okay.
Some of the, if you want to address some of this.
So I'm going to talk about some of the things about the MOLST, and then if there is more about most questions are upsetting, because I think it's frustrating to all of us trying to respect the patient's wishes, what they expressed as their written wishes, and also trying to do, you know, what's right for them, right? So here's what happened in this case, and then we'll come back, we'll talk about it a little bit. So the crew was unable to contact the power of attorney. They tried, did the right thing, weren't able, and I'm not blaming the crew here, right? They did it, they tried to, right? They discussed with med control at Buffalo General, who said it's okay, right? This person doesn't want to go to the hospital. They have a stroke. They said they don't want to go to the hospital. It's on their MOLST. You know, there's no reason to bring them to the hospital. So they signed the patient off and left the patient there. Here's the thing, is that the nursing home staff already spoke with the son, the power of attorney, who actually wanted the patient transferred to the emergency room. And this is where the problem kind of came up a little bit, all right? This is something we see, and you guys have all seen this before, right? So what do you think happened was an hour or so later, staff calls EMS again, another crew shows up, supervisor shows up there, right? And they did a great job, right? And said, let's try to get the doctor at the facility, med control on the phone, and let's get them to talk and figure out what's right for this patient. That didn't exactly work because of some communication issues. At the end of the day, the power of attorney said, I want to make the best decision for my dad. And to do that, we need to know, is he just septic and needs antibiotics, has a UTI, or is this really a stroke that we don't want to do some aggressive intervention for? And the only way to find that out is to do some labs and to do a CT in the ER. And they were trying, the power of attorney was really trying to do the right thing that their father would have wanted and needed that information to do it. All right. The problem we run into, and you guys, I think this is where the frustration comes. It's not just the MOLST. It is very often when we show up at a facility, it's not always the person who has the most information that greets us at the door. And so we talk to clerical staff, somebody who happened to be walking by with a cleaning cart, or whoever, or no one happened to be there. And so one of the things that we really need to try to do is to try to talk to that nurse or the supervisor and really kind of find out, or the provider, and find out what's going on and why that person needs to be transferred, or why they want to send them to the hospital, because that can solve a lot of these problems right then and there. So one of the issues that comes up with the MOLST, and I'll come to you in a second, Brian. One of the issues that comes up with a MOLST is if a patient says, these are my wishes, this is what I want done, the question is, well, how can a family member override the written wishes of a patient? The problem is that MOLSTs, right? The language can be confusing to lay people. They can be confusing to us. They are somewhat subject to interpretation, and I'll show you some, what the wording is in a second. And if you go, like most states, including New York, have a Family Decision Act that says if you are incapacitated and can't make medical decisions for yourself, here's who can make decisions for you, and here's the order, right? And it usually starts with a healthcare proxy or power of attorney, and then it goes to, you know, spouses and children, parents, and et cetera down the line. All right. But if you think about it, when people sign these forms, they're not thinking of every single nuance. And so it makes it difficult for them to really understand in a situation. And when you're faced with this person's confused or they're lethargic and maybe they have a head bleed and they're going to die, and no, they certainly don't want neurosurgical intervention, but maybe, right, pretty common, pneumonia and UTIs, they just need antibiotics and they'll do fine. Sometimes people would want that and would want that treatment. And so they don't think of that when they're signing a MOLST like that. So I'm going to pause there for a second. Brian, you had a question?
So a couple of comments, couple of questions.
Sure.
I just want to ask you, because I do see the note on the bottom, and I think this is the call I'm thinking about.
Uh-huh.
Comment on the time that we spent with DOH and
Yeah.
but the comments that we got
Mhm.
that are worth review. It's difficult to advocate for the patient, and nursing homes are very difficult to deal with even when we contact med control. When staff talks to family, they usually try to convince them they need to send the family. The question was, is it our responsibility to talk to the POA, or do we just trust that the facilities talk to the POA? And observation is, I feel like the problem we often encounter is that the facility docs send patients out based on an assessment from an LPN or RN who is not really knowledgeable. The MD takes their word to cover themselves. And then finally, the forms are also rarely filled out properly, making them potentially legally invalid and putting us on the spot.
Ooh, that's a lot to unpack. And then Rachel, I'm going to get to your question. So where do I want to start there? So let me start with a couple of things, because I think that those were all very valid points and things that make these very difficult and very nuanced. So two things happen. I think people are familiar that we had some issues with the adult care facilities. So adult care facilities, right, which are like assisted living, are different than nursing homes in New York State. There are five levels, I believe, of adult care facility that I can't remember the nuances, and it's kind of crazy about how they get divided up in regulation. And then there's obviously nursing homes, which have different levels of staffing and a higher level of care. They are two different regulations, two different parts of the Department of Health that oversee them. And they have obviously different capacities and different guidelines they have to follow. That being said, when we worked with the state and the adult care facility, this literally from Twin City went all the way up to the Associate Commissioner of Health for the Department of Health, and involved multiple director levels across the state in clarifying the role of EMS in adult care facilities and assisted livings. And they have actually then held more than one, I think they held at least two statewide, webinars like WebExes on this issue, both for EMS and adult care facility staff, all right, trying to address these issues. So that's number one. Number two is when you think about an adult care facility, right, it's an assisted living, it's not a nursing home. So they are only allowed, they can only keep someone there who is independent, who can get up, is mobile, can do their ADLs and care for themselves, all right? Especially it depends on which level they are in those, I think it's 5 levels of adult care facilities, like I said. So even if they're in an assisted living and their MOLST says that they don't want to go to the hospital, but the assisted living says they can't stay here because they can't walk or they can't toilet themselves, or right, they're not a nursing home, that person ends up going to the hospital because they're going to need to be placed in a nursing home or a different facility. They can't keep them there, right? That's an unsafe environment to leave them in. And so even if their MOLST says, I don't want to go to the hospital, you can't leave them in an unsafe environment, just like you wouldn't take a 4-year-old and say, go ahead and stay home. There's no parent here to watch you, right? That's an unsafe environment, and we're liable for that. We're liable for these patients' care. I will tell you, no one, despite what we teach in EMT class about like, oh my God, you're going to get charged with assault and battery if you take the patient who's demented against their wishes to the hospital. No one's going to sue you for doing what you think is right in the best interest of the patient if they are unable to make a decision for themselves. So that's number one. That part with the state and the adult care facilities, I think, is what Brian was talking to, and this is actually a slightly different case. Now let me answer the other question that was brought up: is it your responsibility to call the power of attorney or healthcare proxy? And the answer is no. If the staff says we talked to the person who is legally authorized to make decisions for this patient, and they said this, just document that in your PCR. You don't have to talk to that person. You can take their word for it. I think that that's appropriate. I don't think that someone's going to lie to you, and you're documenting that. If there's a question, by all means, you call them if the number is there and if it's available. But if it's a pretty straightforward thing and you're taking them at their word, I think that that's a legitimate thing to do. All right. The next is, this case specifically was in a nursing home, and this led to multiple calls and emails between Andy and myself and the nursing home staff, both multiple administrators in the nursing home and 3 of their physicians on the call. All right. So my plea is just be nice and work with these people so I don't have to spend so much time on these conference calls. All right. But I'm joking. It was actually a very good, a very productive call. And they looked at it and they said, what are the system issues that we can fix? And their concern, they had a couple of concerns that were brought up, right? And part of it was the person on their end, staff member, giving us the information initially wasn't the right person who had all the information. And that's something they said they could fix on their end, and they owned that, right? We tried to involve med control and tried to do what we thought was right, and did things from our end, and we kind of educated them on our perspective and how things go. But they also brought up an important distinction, and I think this is what a lot of our providers are not aware of, and I wasn't actually really completely aware of specifically until we talked to them. Nursing homes, because they're governed differently in New York State, they actually have to report patients when they get transferred out because of injuries, falls, and other things to the state. And they actually get scrutinized by the state for sending people out who don't need to go or go inappropriately. Way different than the adult care facilities. And a lot of times we look at these facilities like they're the same, nursing homes and adult care facilities. But their staff was very receptive, and they found that in going through their internal review, right, there were some things we could have done better communication wise, but they admitted some things they could do better. As a result of this review, they actually went in this specific system, and they went through every single patient, every single MOLST form, made sure they were filled out completely, and that they were the updated forms that just came out last August, because they were revised. And some of you know there's some differences on the new MOLST form. I see some heads nodding. So this facility actually, as a result of this case, went and made those changes. All right. But there's still some, I guess, room for interpretation in those, and I'll show you. Right, so it is a little bit small to see on the right. This is the new MOLST form. If you look to the right of the screen there, and it says future hospitalization or transfer. And it says check 1, send to the hospital when medically necessary. Right, medically necessary. That's a pretty vague statement. Send to the hospital only if pain and severe symptoms cannot be controlled. Well, what symptoms and what is controlled? Right, that's open interpretation. And the last one is do not send to the hospital. So one of the questions when we had this conversation with the nursing home is they said those first 2, send to the hospital when medically necessary, right? Or only if pain and severe symptoms cannot be controlled, right? Those are subjective. And they said, we think, since we know the patient and their baseline and their family, and we care for them all the time. And I will say, granted, this is probably one of the nursing homes that is truly up on their patients and may not be the norm, but they were legitimately doing the right thing. They said, we know that patient best. And so we are best able to say if we can care for them here, if there's a change, or if their pain and symptoms cannot be controlled. Someone may have a lot of pain that is not controlled, but you may see them at a snapshot in time and they look relatively comfortable. But as soon as they go to get them up to eat, they're in excruciating pain, right? And that was one of the things we discussed. So if they're telling us that this patient, that it is necessary for them to go, or that their pain isn't controlled, or they have symptoms that they think need to be worked up so they can treat them appropriately, we owe it to them, if they're trying to do the right thing, to really take them at their word and work as part of that healthcare team to get the right care for the patient in their best interest. All right. And I think everybody accepts that. Let me go to Rachel and then you. Yeah, Rach.
So, this kind of answered my one question, because do not send to the hospital unless pain or symptoms are severe. So I guess that makes it a little bit easier to clarify. That one was hard.
Yes.
Hospital, but it was one gentleman that had fallen. He had Parkinson's and was shaking, and his leg was on like the door, so he didn't open at the point that we got there, he'd been down for quite a while.
Mhm.
It had gone all the way down to the bone, the cut. So that would be under the pain and severe.
Yep.
This makes it a little bit better. The other question I have is, do you think that in some instances, they're afraid of the patient getting too worse? That if they do call and it's not medically necessary, then they get billed or charged or in trouble, whatever it is. But then they wait and then septic or.
So it's funny you bring this up, right? And it was actually one of the things I was going to bring up in a later slide is that I hear two complaints about nursing homes, and I hear them equally frequent from our EMS providers. I hear they called us for nothing, they didn't need to go, or they waited way too long and the patient almost died because of what they did or didn't do, right? And there's no middle ground. And the problem is, right, again, we're seeing that one point in time. And if they're trying to do the right thing and they're trying to not send out every single person right away, then sometimes people are going to get worse, right? The other option is you send everybody and half of them didn't need to go, and then we're just wasting resources and money and things like that. And so it is a delicate balance, and you're not always going to get it right, right? Even people in hospitals get worse sometimes, right? So just because they went to the hospital doesn't mean they wouldn't have gotten worse anyways, just like they did in the nursing home. And I think that's an important point that you bring up, is that we really have to look at it and say, sometimes they're trying to do the right thing, and sometimes it's not as easy as it seems to us, right? In retrospect, if the patient's crashing and about to code, they probably should have gone earlier, but it's easy to say now, maybe yesterday it wasn't so easy to foresee that and so that's important. And again, even if they had gotten that treatment in the hospital, doesn't mean, some people are still going to get sick or die anyways. So that's a very good point. Jamie.
Patient that has a dementia history,
Mhm.
is currently a learned organization. We answer all the questions for it.
Yeah, so the question is, for those of you that didn't hear, is let's talk about the demented patient who has a dementia history, but seems to be alert and oriented right now, right? And that's where I think you have to really rely on the staff there and the history that you're provided, right? If someone's demented, right, a lot of people don't have the cognitive reasoning and processing to understand the risks, to understand the implications of those risks, to truly give implied consent or refuse care, despite the fact that they might know it's Tuesday, August 1st, right? And so that's a tough thing. And if it ever gets called into court and someone says, well, they told you they have a dementia history, and the family says they definitely don't understand what's going on, they tell everybody it's green, right? Like those types of things come up. Greens, that doesn't make sense in this, I see your face, right? So it does call into question whether they have the ability to refuse or not. I think that those are the instances where you have to rely on family and staff and then involve med control in this decision making, but these are not clear cut. We want black and white, but these are definitely not always black and white cases. Brian.
Couple of points.
Yes.
Lots of comments on the general state of healthcare system and nursing homes. I think maybe just the idea of not to enter with a bias, right? It's all patient centric. But if anybody has an issue, and I know that you, Andy, and I at varying times, subsets of us have tackled this issue.
Yeah.
Anybody who wants to follow up or sees a repetitive issue, let us know. Any one of the three of us will follow through the channel, let a supervisor know, and they'll let us know. We'll follow up with nursing homes, we'll follow up with administrators, clinical staff. We'll certainly endure the phone calls with the state and the state nursing home leads that we went through.
Mhm.
And just a point that really was interesting was Jill just messaged and said that she believes, not 100%, but pretty high degree of accuracy, that only one of the memory care units in our common call area
Mhm.
is actually also any sort of skilled nursing. So they don't have the capacity if somebody has a clinical issue to address it in those, they're assisted living.
So most in our area are assisted living, not actual nursing homes. And that changes the total scope, right? We see people in the ER all the time that come from assisted living and they say, this person cannot go back. And you're like, well, they're not really sick. And they're like, well, yeah, but they can't walk and we can't take them back. And it may just have been a progressive decline, but it is not safe to put them back in that environment. We see that all the time. So, one of the things Brian did say, and I don't know if you guys at home could hear him talking or not, but is that if you have a concern about these things do happen, but I think we've made a lot of inroads, Brian and Andy and I, in a lot of these cases with the administrators and the staff there. We are happy to call if you have a case you're concerned about and take it back to them. And like I said, this nursing home we talked to, they were very receptive. They owned a lot of the mistakes that they made of their staff, and then they changed their whole paperwork process to make sure that they change things on top of it. So we feel like sometimes like nothing ever changes, and the reality is that's not true. And we're happy to work at these things on your behalf. So I'm going to keep going because I know we could talk about Wolf's and stuff all day, and I want to get to some AirTrack stuff in a second. But here's a quick case in a nutshell, right? Here's a female at Wellnow for a rapid heart rate. So we moved out of the nursing home setting. This female's got a history of AFib, MI, diabetes. She complains of some palpitations, shortness of breath. EKG shows AFib at 108. She's got blood pressure's okay, respiratory rate's 22, pulse ox 92, wheezes and crackles throughout. You show up in the room. The patient says they're unsure why they're being sent to the ED, and all that you see there is a tech who says she needs to go for AFib. And here's the question. What do you do in this case? Sign off the patient, heart rate's controlled, there's nothing else EMS is going to do. Apply CPAP to treat the CHF, right? The respirations were 22. Give cardizem because they're tachy and symptomatic, or speak to the provider about why they're sending to the ER. Right, we've talked about this and we've beat it to death, right? The right answer is get more information from the provider. We have also worked very much with Wellnow, specifically at the urgent cares, about issues and have a process for sending cases back and forth. And one of the things we see very often, again, is that like I've sat in the ER and heard the secretary call for a transfer and call the ambulance and tell them something that had nothing to do with why the patient needed to be transferred, right? This patient did not need to go for AFib, right? Like you look at this, like the heart rate's 108. It was not the AFib. It was the fact that they had new onset CHF and they were concerned about an NSTEMI and needed a troponin and workup and that. And so getting that information from the staff is important. So we've talked about this, so I'm going to kind of go through in the interest of time here. And, you know, I guess my take home point here before we move on to the last case is most of these things can be solved just by speaking to the provider or the nurse or supervisor there. All right. And if we really look at that patient-centric approach, like Brian said, and it's not just what's creating work for us or that this form says this or that form says that, really about what's right for that patient at that time, that'll solve a lot of the problems here. So last one. All right. So this is a patient from a nursing home and kind of talked about this. I think, Rachel, this kind of goes with your comment. So you have a patient with dementia, falls in a nursing home from standing, was witnessed yesterday, helped back to bed. Now she's unable to ambulate. You get there, the right hip is shortened, it's rotated. You're concerned about a hip fracture, and you feel that the nursing home was negligent by not sending it to the ER immediately and caused the patient more pain and suffering. So in that instance, how would you handle this? Should you speak to the supervisor and tell them they were abusive to the patient? Report the incident and concern to your supervisor, EMS supervisor? Report it to the State Department of Health, or report it to the County Adult Protective Services? Lots of choices. All right. Yeah. So the best way to handle this, everybody got this right, is talk to your supervisor. Right. I actually had an EMS agency, not here, but actually went and reported somebody to a nursing home to the state, like, because they thought they were abusing the patient. And really, they said, we don't want to send everybody out to the hospital. We tried, like, they're in a no-win situation. They tried to care for the patient. The patient didn't get better. They sent them the next day. Anytime you involve a regulatory body or the state or the Department of Health, they will find something wrong, and they will find something wrong with the EMS care also, and you do not want to invite that scrutiny of the case. It is best that we handle those with our administration and their administration, and like we already said, we're happy to do that. So I'm going to skip through the last couple of things, which is it's easy to throw stones. We don't understand other people's perspective in the healthcare continuum. So we'll skip through that and get to the last case I have before we go to some AirTrack videos so we can kind of end up on time. So this, again, is a real case here at Twin City. This is a 67-year-old female. The call, she was not alert, has a history of hypothyroid disease, hypertension, diabetes, and renal failure on dialysis. She's laying in bed. Initial assessment was complete. She's kind of lethargic in that. and the EKG was done on arrival, and here is the EKG. I'll leave that up there for a second. So you can look at it and you can see it at home, hopefully. All right, so what do you do? Give calcium and bicarb on standing order for arrhythmias, cardiovert this patient, call med control to give calcium and bicarb, or transport hot for emergent dialysis. And so the right answer is call med control for calcium and bicarb, right? So what is the diagnosis here in this case? It's hyperkalemia, right? So you're getting a widening of the QRS and you're getting that almost sinusoidal pattern there, right? So calcium and bicarb are on standing order in cardiac arrest if you think it's hyperkalemia, but if it is not an arrest, you have to call med control to authorize, which is what this crew did. It was quickly identified this, the paramedic did, called med control and got the orders for calcium and bicarb. Just real quick, if you don't remember, hyperkalemia, right, is potassium. Potassium is involved in the function of your muscles, nerves, electrical activity in the heart. And the big causes we see in EMS are two things, really. Either we see impaired excretion, which is like renal failure, especially patients on dialysis, or the majority of potassium in your body is where? It's in the cells. And so if those cells break open, they release potassium. So we see that in crush injuries. We see it in rhabdomyolysis, right, which is a way of those muscle cells being burst open or crushed, right? So the old lady who falls on the floor and is laying there for 12 hours, we can see it there. Burns, we can see that usually happens in severe burns like 24 hours down the road, though. All right. So this is the actual monitoring strip here. The patient did get calcium and bicarb. And if you look what happened, eventually, once you start to get that much widening and you get to that sinusoidal pattern, right, what happens? The next step is asystole, right? And that's exactly what happened in this patient, despite, recognition and the treatment, just because the potassium was that high. So remember, just as far as hyperkalemia goes, the signs and symptoms you see, it's very non-specific with just some muscle weakness, numbness, abdominal cramps early on. You can get palpitations and then the arrhythmias. But the big thing you're going to see in the EMS setting is the EKG changes of first your peak T waves, then the widening of the QRS, and then the sinusoidal pattern like that. Sean. Yeah, so they called, so our paramedic actually identified that as being hyperkalemia, called med control, got the orders for calcium and bicarb, and as was giving it, the patient actually coded. So, and they gave calcium and bicarb, worked the code, did get ROSC, the patient ultimately ended up dying, correct, Kelly? Yeah. Yep. So, good. Yes, Rach. It was a dialysis patient. I don't think the patient missed any dialysis sessions at all. Sometimes that's a good question, right? Because certainly if they miss dialysis, they're at higher risk for that hyperkalemia. Sometimes things just progress and it builds up, and that's what we see. So, so that leads me to my next question, since we're on, and this will be the last question here, is what is the role for calcium and bicarb in cardiac arrest? They're worse for survival when routinely given. Part of the H's and T's, so give for anyone in asystole that doesn't respond to epi, should only be given for specific indications, or second line cardiac drug for all codes greater than 20 minutes, select all that apply. All right, and so the two correct answers are they actually show when routinely given. This is one of my pet peeves, and some of you have gotten emails from me. We used to give calcium and bicarb to all codes. Everybody was down. It was a second line cardiac, medication. Now all the evidence and more studies coming out every year that show it actually has a worse outcome for people when routinely given. What happened there?
I was just bringing up your other.
Oh, I wasn't done. Jeepers. Oh, it's hard to find good help.
What's your last slide? Tell us we're finished.
Well, they want to see who won with the most points.
That's why I was getting rid of it.
Oh, geez. All right. Why? Because you didn't get to play? What a sore loser. So it's worse for survival when routinely given, and there's more data on that. We should only give them for specific indications such as hyperkalemia, right? Calcium, if it's a calcium channel blocker overdose or things that you're probably going to involve med control in and things like that, but should not be given routinely anymore. So good job on that. So that leads us to the end. And we'll see the high scores. I have no idea how there's like not that many questions, but people end up with a score of 9,000. Oh, is that what it is? All right. Well, there you go. So those are all of the questions there. Again, different format, but I thought it was different rather than sitting up here and just kind of lecturing to kind of throw in the cases. You can switch now.
We good now?
I'm good now. Thank you.
Sure.
Yeah, I'm positive. Yeah, no, go ahead. You do you. All right. But I thought it'd be a little bit different. If you guys like it, let me know. If not, we'll go to something else in the future. But rather than just getting lectured to, this way at least, I think sometimes if you ask questions and people get to choose, sometimes it helps you remember things a little bit. Yeah, especially Brian when he doesn't get to play. Oh no. All right, edit that out. So I'm going to go through just a brief review, in the last 15 minutes here of some AirTrack's just kind of review of video laryngoscope use. And it's been a while. We probably need to do a whole section just kind of on a whole lecture on that again. But I'm going to go through just a review of placements and some things that we want when we're looking with our video laryngoscopes. Then I'm going to show some AirTrack videos actually from cases here, some good, some bad in that. So first thing I want to kind of discuss, and we talked about this is probably before COVID when we did an airway lecture and I talked to you guys, right, is about the EVLI approach, right, or epiglotoscopy, volleculoscopy, laryngoscopy, and intubation. What I want you to remember here is the goal is not to look for the cords right away. What we see in new paramedics and novice providers is they put in the blade, they go way too deep, they have no idea what they're looking at. Sean and I just looked at a couple videos today that it was clear no one knew, they didn't know what anatomy they were looking at or how to find their way out of there. So the way that you correct that and the way you have more success in your intubations is to progressively advance the scope and to identify the structures as you go. So as opposed to the old days of like sweeping the tongue out of the way, which is better for direct laryngoscopy, when you're using a video scope, you can go right down the midline, all right? Because you get a much better view of that camera with a camera there, especially with the channel blade we have in the AirTracks. So go right down, look at the uvula, stick your blade right down the midline, and as you're advancing it, you're going right around the base of the tongue, and you're going to start to look for the epiglottis. Once you see the epiglottis, then the next step is to continue advancing till you see the vallecula, right? Remember, in a video laryngoscope, our goal is to use it like a Mac, where the blade is seated right into the vallecula, not underneath the epiglottis, all right? If you are under the epiglottis and not in the vallecula, and I'll show you a video, it changes the angle, and this is where a lot of people get frustrated with AirTracks because they can't advance the tube. They have a beautiful view of the cords, but they can't advance the tube because they don't have the right angle, and it's because they're not actually seated in the vallecula. Once you're in the vallecula, you want to advance the tip to all the way deep into the vallecula because there's a ligament there that will open up the view of the cords, and then you'll be able to see the cords, the larynx, and easily pass the tube. So I'm going to show a couple of videos, right, of what that should like, and I'm just going to kind of talk about this. So go ahead and play that, Brian, if you did it right. Maybe I can just hit go. All right. So what you're going to see first on this video is you're going to see an inexperienced provider try to attempt an intubation. And like most providers, they bury that tube and are way too deep. And when you're looking at this, they actually end up being in the esophagus. All right. And this is something we see commonly with our AirTrack videos. So it projects right way deep. You see a hole there, but nowhere near the cords, and it's hard to identify. You're not sure, is that trachea? Is it swollen? It's not. That's the esophagus there. All right. And so the way, there it is above it. As they pull out, then you start to see, pause that right there, Brian. All right. So what they did is they pulled, all right, because you're way deep in the esophagus. As they pulled back, then you saw the cords drop into place. Now, if you look, you cannot see the epiglottis in this part of the video here, right? That tells you that although they can see the cords and although they're passing the tube there, it is still not where you actually want the blade to sit because it is more difficult to advance the tube through this position. You want to actually see the epiglottis up at the top of the the picture screen. Go ahead and play it there, Brian. All right, so they're able to pass it, but you don't see, you're actually under the epiglottis here and you're too deep, even though they get the tube. This is not the ideal location for a video laryngoscope. So in the next part of the video, what you're going to see is you're going to see that they go right, here's your uvula, there's your epiglottis, you see the vallecula, and then when you advance the tip of the blade into the vallecula, you'll see what happens. All right, so they're not lifting or anything there. They just advance the tip of the blade right into the vallecula, and when it hits that ligament, it opens up the view. So, oh, can you advance to the next slide? All right. So, like I said, the view that we actually want here is on the left, and I know it kind of washes out here in the room a little bit, but you can see the epiglottis at the top of the screen. You don't want the view on the right where you're actually below, right? You're almost using it like a Miller blade, if you will, all right? And it changes the angle there. So just on a cross section here, just so you can see, so this is a cutaway. If you're looking at the screen, above the blade there, you're actually seeing the tongue, right? Right there, yeah, thanks, Brian. And then you see the blade, the tip of the blade is positioned in the vallecula there, and below it is the epiglottis. Where that blade is right where you want your blade, your video laryngoscope to be positioned, because that's where the ligament is. And when you hit it, it literally will pop up the vallecula out of the way, so you get a straight view of the epiglottis. Can you play that? I'm sorry, straight view of the vocal cords, not the epiglottis. So here you'll see they lift and you don't see that epiglottis move out of the way. That's if you're not deep enough. And then as soon as you engage that ligament, you see how the epiglottis moves out of the way and changes your view. That's what we're looking for. You can go to the next slide. Nope, next one. There we go. All right, this is just another video. Again, it's showing that ligament there, and it's showing you that now instead of looking at a cross section, what happens is you can actually see the ligament here above the epiglottis in the vallecula there. And they tried lifting, and you're not getting any good exposure because you're not deep enough and seated in the vallecula. Versus when the tip's advanced into the vallecula like that, it opens right up out of the way. All right. So everybody's understanding that? Any questions on that so far? All right. So here's some real videos. We're going to watch some of these, then we're going to pause them and we're going to talk about them. Some are good, some are not as good. So we're seeing the epiglottis there at the top of the screen. Everybody sees that? Not really seeing the cords at all here. There, oh, there's some cords right at the bottom. Nope, now we lost the view there. There's the epiglottis again. So we saw a glimpse of the cords, but we're not seeing them. Now you're seeing some CPR, you're seeing a little bit of fluid there, but we're not able to see the cords at all. So what's the problem here? How come we're not able to see the cords? Yeah, so it's not in good placement specifically, right? It's not deep enough. We're not deep enough into the vallecula. You can see the whole epiglottis. We haven't advanced the tip of the blade into the vallecula. And if we did, that would give us a better view, allow us to expose the vocal cords more. We saw a glimpse of them at one point, but that's why they're struggling so much with this intubation. All right, there's the cords again, but you can almost see the space between the top of the blade and the epiglottis there, right, where you're not advanced into the vallecula. Now there's a lot of CPR or fluid or something, so. Any other comments on this? Sean? This is a long intubation, right? So if you're struggling this long, right, and you still haven't been able to intubate, should we still be trying to intubate? No. Now I know sometimes I'll say, if we're doing CPR, right, I don't have to worry about bagging them. You know, don't do that silly thing where you hold your breath and you try to like see if you can intubate while you're hypoxic and stuff and before you pass out, like they used to tell people, right? But we probably shouldn't be trying to intubate for 2 minutes and 30 seconds. All right. Even in cardiac arrest. So if we should, I am still a big proponent of trying to intubate cardiac arrests rather than dropping LMAs. Although there is some data, you know, kind of about debating what the right answer is and which is better. But I think we can all agree that if you don't get the intubation after your first attempt or after, hopefully way before 2 minutes, we need to go to a secondary airway and go to an LMA. All right. I think that that's a no brainer, but this was a little excessive. Also, remember, I talked about this before. Every time, you know, every subsequent intubation attempt increases the risk of complications, right? This patient's already in cardiac arrest, but certainly isn't going to help their survival chances at all. So next video, let's go to the next one and see how this is. It's like a lot of fluid there. There's the cords at the top. What do you think about the placement there, the blade placement? Too low, right? So we are not in the vallecula, we're underneath the epiglottis there, right? There's also a lot of fluid. Now that there, you can see, yeah, so we can kind of almost see, you could get a glimpse of the cords there. Stop that, Brian. So you could see at the end, there was almost a glimpse of the cords there. But then when they started to pass the tube, they had lost the view of the cords and it almost became like a blind intubation. So first they were too deep, then they were almost in the right spot, but you got to make sure you have a good view before you try to pass the tube. Next one. I think that they were trying to advance it. I think they're almost trying to advance it too soon, but you're right about that. All right, so there's our epiglottis. Oh, what do you think of that?
Way too young.
Yeah, so can you rewind that and start again, Brian? So let's go back. All right, yep. So, oh, that was the end of that one. All right, so I'm gonna tell you when to pause it, Brian. Right there. All right, so here you guys see the epiglottis right there, right? And you can see where the vallecula is. So right where that arrow is, right, that's the epiglottis, and right above it's the vallecula there is right where we want to be putting the tip of the blade to get the best view. And then what you see, you can go ahead and play it from here, is, right, they're almost trying to put it on top of the epiglottis, right? There's no visualization of the cords, and that basically is just a blind airway insertion that is not going to go well, right? That's going to end up right in the esophagus and did not go the way it was planned because we didn't visualize or appreciate the structures, right? They were trying to pass it through the epiglottis. Yeah, so before you play it, so I guess one of my take-home points is intubating isn't really anything that is that difficult. Really what it comes down to is identifying your structures. If you can identify what you're looking at and know where you need to place the blade and know how to correct it, then you're going to be a lot more successful. If you're just kind of going in and hoping you're going to see something, you're going to miss every time. You're going to see the esophagus. You're not going to know what structures you're looking at. Or if you're trying to just pass a tube and hope that it goes in, that's just asking for trouble, right? We see people vomit. We see a bunch of stuff coming up the tube. You're better off if you can't visualize the cords, just take the blade out and go right to an LMA if you can't. All right, go ahead, next one. Just a few more and we'll be done, guys. Thanks for hanging in with me here. If you're wondering, we got lots of video of the inside of an ambulance. Oh, here we go. This airway. This is a juicy one. So here we see the cords where, pause it, Brian. A little hard because of the shading, right? But you can see the vocal cords there on the top. You can see the false cords on the bottom there, all right? This was an upper GI bleed with lots of secretion in the airway. And we'll go back and look at that in a second. What about the blade placement here? It was under the epiglottis. So did you back it up, Ryan? Yep. All right, play it again here. So look at all of this. That's like coffee ground emesis, dark GI bleed. Look at that. You can see that fluid kind of streaming right into the cords there, right into the trachea. This paramedic did a great job of suctioning, right? We see a lot of issues with suctioning and actually employed the salad technique, which I'll talk about in a second, to clear up this airway. And so as she was suctioning, actually took the catheter because it was an upper GI bleed and took the suction catheter and put the catheter into the esophagus, which is what helped get better visualization. Now, so hold it, pause it right there. So even though that blade was below the epiglottis and not in the vallecula, she was still able to pass the tube. But that was a great technique and I know Sean and Brian have talked about this before, the salad technique, is if you're suctioning and you have tons of secretions or vomit or GI bleed up in the airway, is not just suctioning so you can see, but actually taking the tip of the catheter, dumping it in the esophagus and leaving it there during the intubation, which just gave you a great visualization, took out all that coffee ground emesis there and allowed the tube to be placed. Was a great job of the intubation. Even though the tip could have been in the blade could have been in the vallecula, still able to visualize and to navigate the angle, which was good.
Looks like this suction tubing down here.
Yeah, the catheter, you can see a little glimmer of the catheter there. Yeah, that's an excellent job and an excellent airway. We do see a lot of videos where people do not suction enough or don't have suction ready. And then it just leads to all kinds of secretions and don't get good visualization. Rachel.
Have you noticed more GIP code?
I don't know that I've noticed more than usual. If you've seen an uptick, maybe you just happen to be a magnet for them. I guess you're asking, usually when people ask, they've seen a lot of them. So I don't know that there's more, that I see more than previously, but I will say, we do get some good videos of upper GI bleeds, both coffee ground type stuff and sometimes even bright red blood.
The one with Snyder.
Yes, it was. Yep. Go ahead. Nasty one. Yeah. All right, where are we? Yeah, so we are under the epiglottis. We are too low. You're right, and Jamie, we're too close. And this is the problem you run into when you're not in the vallecula, when you're under the epiglottis, is you have trouble. You hit the posterior part of the pulse cords there. You can't get the tube. And this is when people get frustrated because they have this beautiful view and they're super close and they can't get the tube to pass and they think the air tract stinks. And really it's because they're in the wrong spot. All right. And that's the teaching point there, is to make sure that you can actually, position yourself that you are underneath or in the vallecula, not underneath like this, so that you don't run into this problem. You can just let it play.
I was just gonna,
Good.
looking at the tube. The green line I just put up there, if you can put the glottic opening below that green line.
Yeah, so what Brian is saying is basically when you're going through a video laryngoscope or the air tract, right? You almost want your target, right, which is the opening of the vocal cords, to be in the middle of the screen, almost like if you drew a bullseye or he just drew that line kind of bisecting the screen there. If your vocal cords are up above it, then you're probably too close or under the epiglottis and not positioned in the vallecula, and that's why you're not able to get the tube to go. So that's a good point. No, just let it go. So this is the second attempt on this patient. All right, you can just see it's coming out of the trachea. That looks nasty. All right, same problem here, right? Still too close, still under the epiglottis, and still can't get that ET tube to pass. If you just, from this position, if you just pull the blade back a little bit, let the epiglottis flop down, and then advance the tip of the blade into the vallecula, you get have a much easier time of navigating this angle here. Right there, that's where we want to be. And then you see how easy that is, right? We're a little off center, but you see how once you do that, how easy it is to pass the tube, that's where we want to be. And finally, they figured it out. We're good. We'll keep going. I think there's only a couple more guys and then we'll be done. That's all right. So here we go. Here's another upper GI bleed. All right, now this, pause it there, Brian. What do you think about this placement? So there you can see, it's kind of doesn't project well, but what's that? That's perfect, right? So it's right where we want to be. You can see, right, the blade. You can see the epiglottis at the top of the screen, the blades in the vallecula, and you get a beautiful view of the chords. It doesn't project like a beautiful view of the chords here, but it does on the screen and it does at home, right? So play it, maybe it's just the angle as we play it here. So that's kind of right where we want to be. That's a nice view there. And then if we advance the tube, right, easy, you don't get hung up on the posterior chords. The other thing I see a lot of times is when people pass the tube, they pass the tube and they are quick to rip the scope out of the mouth. And what's that? So if you're ripping the scope out of the mouth, like right after you pass the tube, and I can't actually tell if the tube passed the chords or not because you took the blade out so quick, and I have the ability to pause the video, then that means you probably didn't know that you were actually able to successfully pass the tube or visualize the chords in the tube passing through. So just another point is as you advance the tube, just get that picture, get that confirmation, take a second, take a breath, then take your blade out. So good. Any questions on the airways and the air tracks and stuff like that? Again, I've said it before and I said it at the company meeting. When you're uploading these, you're giving them to the supervisors. I know it's hard. I'd be happy to go through these with anybody, but my days and times of when I'm here every week kind of changes. So I'm happy to sit down and go through this stuff, or if you want to call and talk about these. But I think the best thing is we have a great advantage of having the air tracks and having the video. When you go to upload them, sit down with the supervisor and go through. And I know some of the supervisors are really good about doing that on their shifts with people, or, talk to Kelly or Brian or Sean or Jeff or whomever, and just kind of go through these if you have questions on. There's a lot we can learn, a lot from the good ones and a lot from the bad ones. And we'll try to keep pulling these as we do some case reviews every few months. I'll try to pull out some videos like this just to go through if you guys find them helpful like that. All right. So Sean, you got a question?
No.
Oh, sure. Go ahead. Yeah.
Here and listening. I see it a lot during rematch skills, Jeff, here and L2 with the skills. You get a lot of very experienced providers come in, they don't like the skills. I've done this before. I got it. Then they'll sit down with a 20-year paramedic, can't find the pacer. I'm not judging that paramedic. It's just that paramedic hasn't paced somebody in 5 years. They haven't done it. They just can't. So I really want to encourage you guys. Don't feel stupid. Don't feel like you're, not a good provider, because you have to go over things. Let us know. We have time. We have facilities here. That room's always open with the mannequins in it. Your track's always in there. You can always come into practice. But don't feel like you're less of a provider because you have to come into practice. You've been in the job 20 years. It's great. I respect that. I don't need that a lot of knowledge. But if you're not using these skills routinely, they degrade like anything else, right? So stop in. Grab me, grab Jeff, grab Kelly, Brian, the supervisor. Hey, I want to go with the air track. I want to intubate. I want to play with the monitor. It's all here for you guys. You don't feel silly about asking, right?
Good. So any other questions or comments? And then I'll ask a question. Nobody? I'm looking at the chat online. I don't see anything else there. So
Just appreciation about the.
yeah, so I saw Nick's comments there about the hybrid format and stuff. What do you guys think? And if you're at home, you can unmute and stuff and yell out. What do you think about using the case presentations and using Kahoots like that? Is that better? Is that worse? You guys like that? You guys like it? All right. Better than just being talked to for an hour and a half? All right. So the consensus here, at least in the room, is that people like the Kahoot format. If anybody has comments online, if you want to put them in the chat, or you can unmute and tell me what you think, but we want these to be a little bit more interactive. We want them to be useful for you guys. We want them to be things that you'll remember and take home points and things like that. So you can email me afterwards if you have questions. You can put them in the chat or tell us what you'd like to see or what you think would work better. But we want it to be about how we can communicate that information to you guys and have you guys get the most out of it. So that being said, I know it's after 8 o'clock already in that, so I won't hold anybody up any later. But if you have any questions, feel free to reach out to me, or we can chat afterwards for those of you in the room. But I appreciate everybody coming out or joining us online. And unless Brian has anything else, no.
Just thank you, everybody.
Then-
This, seems like well received and people enjoyed it.
Yep, I appreciate everybody turning out tonight, and we'll talk to you soon. Thanks.